Welcome to the Explainer. Today we're setting the stage for a really critical diagnostic showdown. We're looking at two pathogens that can actually look remarkably similar at first glance, but they demand entirely different approaches. We're diving deep into the clinical crossroads of diphtheria and streptococcal pharyngitis. And let me tell you, getting this wrong isn't just a simple mix-up, it is quite literally a matter of life and death. Let's jump right in.
Picture this. You've got a patient sitting right in front of you. They're complaining of a terrible sore throat, and when you take a look, you see a prominent exudate. Now, your mind probably jumps straight to strep throat, right? It's common, it's pretty straightforward. But a quiet little alarm bell should absolutely be ringing in the back of your head. Could this actually be diphtheria? How you interpret the subtle clues in front of you over the next few minutes is going to completely dictate this patient's outcome.
So, here's our roadmap for today. First, we'll look at the pharyngitis crossroads. Second, we'll directly compare diphtheria and strep pharyngitis. Third, we'll break down their pathogenesis and treatment. Fourth, we're going to look at some dangerous related diphtheroid pathogens. And finally, we'll wrap up with an urgent antitoxin warning.
Okay, Section 1, the pharyngitis crossroads. Let's decode that exudate.
When it comes to diphtheria, which is caused by Corynebacterium diphtheria, you aren't just looking at your run-of-the-mill exudate. You're actually looking at a pseudomembrane. It's got this distinct gray or white color, and here's the absolute key difference you need to remember. It is firmly adherent. If you try to scrape or pull that diphtheria pseudomembrane off, it will actively bleed. Now contrast that with streptococcal pharyngitis, usually group A strep. That exudate is loosely attached. You can easily swab it or remove it without triggering that aggressive bleeding.
Now, when we check the spread of the infection and the patient's vitals, we see a really fascinating, kind of counterintuitive clinical picture. Strep pharyngitis generally stays put in the pharynx, and it usually spikes a classically high fever. But diphtheria, the much deadlier of the two, actually presents with a low-grade fever. It's a huge red flag. Plus, that aggressive pseudomembrane we just talked about doesn't stay in the throat. It spreads downward, creeping into the larynx, the trachea, and the bronchi, physically threatening to block the patient's airway.
Moving on to Section 2, diphtheria versus strep pharyngitis. Let's talk about the systemic threat.
Okay, so the timeline of danger here is everything. Strep pharyngitis threatens patients mostly after the initial infection with immune-mediated sequelae. We're talking about things like glomerulonephritis and acute rheumatic fever. But diphtheria acts like a ticking time bomb of direct, severe toxicity. Just 1 week in, patients are at extreme risk of developing life-threatening myocarditis. And if they manage to pull through that, anywhere from 3 to 5 weeks out, they're hit with the onset of debilitating polyneuropathy.
Let's pull all this together into a master comparison table. It's amazing how perfectly these two pathogens contrast. On one side, you've got the firmly adherent, bleeding pseudomembrane, the downward spread, and the low-grade fever of diphtheria. On the other side, the easily removed exudate, localized spread, and high fever of strep. You can clearly see the direct toxin-mediated myocarditis and neuropathy of diphtheria stacked up against the post-streptococcal complications of strep. Oh, and notice the vaccine difference too. We have a highly effective toxoid vaccine for diphtheria in the DTaP or Tdap shots, but there's no licensed vaccine for strep at all. This table right here is your ultimate high-yield clinical anchor.
Section 3, pathogenesis and treatment compared. How they attack, and more importantly, how we fight back.
To truly understand why diphtheria is so deadly, you've got to look under the hood at its weapon of choice. The diphtheria toxin is a remarkably potent exotoxin. Down on the molecular level, it causes the ADP ribosylation of elongation factor 2, or EF2 for short. By doing this, it literally hits the brakes on protein synthesis inside the host cells, just shuts it down completely. That cellular destruction is the exact mechanism driving the crazy pseudomembrane formation, that severe myocarditis, and the delayed polyneuropathy. Strep, conversely, leans a lot more on direct tissue invasion and its own distinct streptococcal toxins.
Because their attacks are night and day, our treatment strategies have to be too. For strep pharyngitis, a standard 10-day course of penicillin generally does the trick perfectly, mostly just to prevent that acute rheumatic fever from popping up. But diphtheria, that requires a massive, urgent, two-pronged attack. You absolutely have to give an urgent antitoxin to neutralize the poison in their system, and you pair that with a 14-day course of erythromycin to wipe out the bacteria that's pumping it out.
Section 4, dangerous related diphtheroid pathogens. We're venturing beyond the classic presentation.
First up on this rogues gallery is Corynebacterium ureolyticum. When you see this name, I want your brain to immediately jump to alkaline encrusted cystitis. It's a super specific and incredibly severe urinary tract presentation.
Here's the deal with C. ureolyticum. It is strongly urease positive, which basically creates a highly alkaline environment in the bladder that leads straight to the deposition of ammonium magnesium phosphate crystals. It literally encrusts the patient's bladder. Ouch, right? To make matters worse, it's highly drug resistant. So for C. ureolyticum, vancomycin is absolutely your treatment of choice. And just a quick aside, this pathogen can also cause peritonitis and endocarditis, so keep that in mind.
Next up, we have Corynebacterium minutissimum, which causes erythrasma. This is a pruritic intertriginous rash, meaning it likes to hang out in the skin folds. But here is the amazing diagnostic giveaway. If you shine a Woods lamp over this rash, it illuminates with a brilliant, unmistakable coral red fluorescence. It's like a built-in neon sign. You generally treat it with topical erythromycin, clindamycin, or futissic acid, and save the oral macrolides for the really stubborn cases.
Then there's Rhodococcus equi. This one's fascinating. It's an intracellular pathogen that lives inside macrophages, mostly found out in the soil. But in HIV or immunocompromised patients, it causes a severe cavitary or nodular upper lobe pneumonia. Clinically, it looks so much like tuberculosis, it even stains partially acid-fast. Beta-lactams are totally useless here. Again, vancomycin is your drug of choice, often combined with drugs that can penetrate the cells like macrolides, clindamycin, rifampin, or TMP-SMX.
Let's rapidly hit 3 other vital pathogens to round this out. First, Corynebacterium jejcium. This one causes sepsis in neutropenic or HIV patients, usually stemming from infected catheters, and it is incredibly resistant, pretty much sensitive only to vancomycin and linezolid. Then we've got Corynebacterium ulcerans. This is a zoonotic infection linked to horses, cattle, and dogs, especially if you're in a rural setting over the summer. Get this, it actually produces the diphtheria toxin, so you have to treat it exactly like diphtheria, erythromycin, and that urgent antitoxin. Finally, Archaeonychimbacterium hemolyticum. This causes pharyngitis with a scarlatiniform rash on the trunk and proximal extremities. It mostly hits teenagers and has a very strong association with an Epstein-Barr virus co-infection.
All right, Section 5, the urgent antitoxin warning. This is a life-saving clinical pearl, so listen closely. If you even suspect diphtheria, time is absolutely your worst enemy. You have to administer the diphtheria antitoxin immediately, based purely on clinical suspicion. I'll say that again. Do not wait for laboratory confirmation. Seriously, every single passing hour just allows for more irreversible cellular destruction. Here is your exact, immediate action protocol. Step 1, you form that clinical suspicion based on seeing that gray, firmly adherent pseudomembrane, and you get the antitoxin ready. Step 2 is vital. Do not skip this. Perform a test dose first. The diphtheria antitoxin is actually derived from horse serum, so the risk of anaphylaxis is very real. Once you confirm they're clear and not reacting, Step 3, administer the full antitoxin immediately.
Why the huge rush? Well, here's the catch. The antitoxin has one massive limitation. It can only neutralize free circulating toxin. Once that diphtheria toxin actually binds to a host cell, it's game over for that cell. The antitoxin is completely useless to save it. You can get this life-saving antitoxin directly from the CDC Emergency Operations Center. Their number is 770-488-7100. Oh, and one last vital rule. You might be really tempted to give glucocorticoids to calm down all that inflammation, but studies show they have zero benefit. They absolutely do not reduce the risk of that deadly myocarditis or polyneuropathy, so skip the steroids.
Well, we've covered a lot today. We contrasted the distinct differences between strep and diphtheria, mapped out that scary timeline of systemic destruction, and highlighted exactly why you need that antitoxin so urgently. So I'll leave you with this question to chew on. The next time a patient sits down in your clinic with a severe sore throat and an exudate, will you be ready to spot the difference before that toxin permanently binds? Thank you so much for joining me on this explainer. Keep learning, stay sharp, and I'll see you next time.